This bar chart compares global healthcare expenditures, and the American total easily eclipses the OECD average. When economists break down these numbers, they find a clear culprit. Americans don't actually consume more healthcare or go to the hospital more often than their international peers. They just pay wildly inflated unit prices for identical services. Consider the standard MRI. It is a highly matured, standardized diagnostic procedure, utilizing ubiquitous global technology. Yet a routine, uncomplicated scan might cost $400 at a community-based clinic and instantly escalate to $4,000 if you drive a few miles down the road to a regional hospital. Behavioral economists explain this anomaly using what they call the birthday cake test. In a standard consumer market, buyers have an intuitive baseline expectation of what an item should cost and what quality looks like. If a local bakery tries to charge you $500 for a basic sheet cake, your internal price anchor immediately flags the distortion, and you walk out. In the American healthcare space, this intuitive anchoring does not exist. Patients operate in an absolute information void. Because reliable quality metrics are hidden, consumers default to the flawed assumption that a hospital charging $4,000 for a brain scan inherently provides superior diagnostic clarity than an independent clinic charging a fraction of that amount. Generating a medical image does require a substantial physical investment. Facilities must acquire hardware that can cost upwards of $3 million, construct meticulous radiofrequency shielding, and foot utility bills that can hit $15,000 a month just to keep the supercooled magnets running. This visual breakdown tracks the actual economic weight of a single scan. Because MRI machines depreciate incredibly slowly, international cost accounting data shows the fully burdened physical and labor cost of a single procedure sits around $200 to $300. So the central question of the American medical economy is this: how does a $300 baseline production cost balloon into a $3,000 bill? This flowchart illustrates a uniquely American billing quirk. The U.S. medical system splits a single diagnostic procedure into two completely distinct economic products: the physical execution of the scan and the intellectual interpretation of the results. The smaller portion is the professional component. This fee compensates the radiologist for the rigorous cognitive work of reviewing complex cross-sectional body scans, formulating a clinical diagnosis, and absorbing the malpractice liability. The remaining chunk is the technical component, which pays the facility. It covers the machine, the electricity, the architecture, and the technicians. This technical pathway is also where the hospital absorbs the heavy bulk of its arbitrary markups. Over the past decade, massive integrated health systems have aggressively acquired independent, community-based imaging centers. Immediately upon acquisition, these suburban clinics are legally reclassified as hospital outpatient departments. Even though the clinic operates strictly during normal business hours and lacks a trauma center, the parent hospital exploits a regulatory loophole to attach massive hospital-grade facility fees to every scan. The patient parks in the exact same lot, uses the exact same machine, and consults the exact same radiologist, but the price escalates exponentially. Up to 60% of a patient's $3,000 bill is essentially an arbitrary corporate real estate tax, entirely disconnected from the actual clinical care provided. The physical capital and the monopolistic markups account for only part of the invoice. The United States spends roughly $285 billion every single year doing nothing but navigating the labyrinthine administrative logistics of multi-payer health insurance. In radiology, performing a scan and submitting a clean claim does not guarantee payment. It merely initiates an adversarial negotiation. Private insurers initially deny nearly 15% of all claims, triggering an intensely expensive, labor-intensive cascade of administrative rework and appeals. To survive this hostile claims ecosystem, providers synthetically inflate their gross charges. The $3,000 retail price is a meticulously engineered financial buffer. It is specifically designed to absorb mass denials, write-offs for uncompensated care, and the multi-million-dollar salaries of the billing departments required to wage this endless administrative warfare. A rational market would see independent doctors purchase their own machines to simply undercut these hospital prices. But in 36 states, legislation known as Certificate of Need laws actively prohibits them from doing so. To open a competing clinic, an entrepreneur must first undergo an exhaustive legal process to prove an unmet economic necessity to a state regulatory board. Incumbent hospital systems routinely testify at these exact hearings to protect their own lucrative monopolies, effectively gatekeeping the technology. This legal framework expertly insulates established hospital networks by synthetically restricting the supply of lower-cost competitors while forcing providers to generate massive administrative bloat. The system effectively severs the medical price tag from the basic laws of supply and demand. We know this pricing structure is optional because foreign markets easily bypass it. Japan has the highest density of MRI units per capita in the world. Yet, the Japanese government enforces strict statutory flat scan fee ceilings, keeping even entirely private cash-pay preventative scans highly affordable. Germany utilizes a dual insurance model where patients can bypass the public referral system by paying out-of-pocket at private radiology clinics. Because their national fee scale sets strict parameters, a self-pay MRI in these completely unregulated German facilities averages around $800. Look at this graph tracking recent U.S. policy attempts to curb extreme pricing. The No Surprises Act successfully shielded patients from emergency out-of-network bills, but it forced insurers and providers into an arbitration process to settle the difference. Providers aggressively exploited this system, securing post-arbitration imaging prices rocketing up to 767% above the baseline Medicare average. To strip the inflation out of the system, health economists point to a precise, mathematically sound solution: site-neutral payments. Site neutrality relies on a straightforward economic axiom: reimbursement must be tied explicitly to the clinical resources required to deliver the care, not the corporate designation of the building. If a NASF hospital acquires a suburban imaging center, they are legally capped at billing the standard independent office rate. In fact, the Congressional Budget Office estimates implementing this rule would save American taxpayers over $150 billion in a single decade. The $3,000 MRI is a manufactured economic illusion. True systemic reform requires repealing protectionist state laws to invite competition and mandating site-neutral payments to strip away predatory facility fees. Only by linking reimbursement strictly to clinical value and actual production costs can we restore rationality to the American medical economy.